Are there any other specific questions that you like to ask to help tease things out? Or is it just kind of like the main things that we would ask any nasal obstruction patient?
It's usually a lot of times it's the same stuff. You want to make sure, like, okay, is it one side or both sides? Does it alternate? Like alternating congestion, is usually allergies or some kind of medical related issues. But, everything plays together. Everything kind of has like a stronger impact on that breathing. So, and your job is kind of like as a detective is to try and figure out, all right, well, what's the most efficient, best way that I could help you in the immediate term and the long term. But ultimately, yeah, you just have to take a really thorough history and just think of it from an anatomical and medical standpoint.
And then what's your physical exam like? Are you scoping all the patients?
Yeah. So I always start off by asking. So I scope all my patients, but when it comes specific to the internal external nasal valves, I'll have them just breathe at baseline. Tell me about your breathing. Scale it on 1 to 10. 10 being like the best breathing ever. 1 being you can't pass any air. And I get a baseline for either nostril. And I do this decongested and regular. So I also decongest them after and do the same kind of exam. And then I'll do a couple maneuvers. One is I'll lift up the tip and see if that helps. So where does that bring you on the scale from 1 to 10? Does it take you from like a 3 to a 5? Because that also can, be very indicative of, external valve collapse. And then I also, do a modified or a caudal maneuver where I, pull up on the cheek skin and say, where does that bring you on the scale? Doing it congested and decongested also kind of helps in, figuring out some of the medical related issues. Then I have them take like a deep breath in and I look at the nose. Is it pinching? That's, also a very telltale sign of external nasal valve collapse. And then what I do is I take their photos and then I map their their surface anatomy to their internal anatomy. And I'll do that with them. So I'll take their photo, put it on a screen, and I'll start to draw out those cartilages. So if those cartilages are cephalically oriented, I'll show them and I'll, map that out. And I can, have a pretty strong suspicion that, they might have some external valve issues. Or if they have like an inverted V and there's a mid-bolt kind of pinching, then I'll, correlate that with internal nasal valve. So it's a pretty in-depth process, but I think it really helps you get to understand the patient's really their nasal anatomy and, the nasal pathology that they might be suffering with.
With their response to Afrin, if they're like, oh, wow, that stuff's great. Can I get some of that? That's, it's much better. Would you, correlate that with turbinate hypertrophy or allergies or something less related to the nasal valves?
Yeah, so if like one is that the internal scope exam changes with the Afrin, like they might go from like these pale, boggy turbinates to like, pristine, then, there's definitely some medical, vasodilation and, irritation. But yeah, if their response to the Afrin is disproportionate to the response to just the physical maneuvers of like, lifting the tip up, lifting the cheek skin up, then I would certainly probably try them on medical therapy. And usually I try them on medical therapy if they have, some kind of medical thing in their history, like they do have bad allergies and they've never been on like a Flonase or a steroid. Because even if you have all of this stuff, it might be just that the allergies are pushing you over the edge. So you might have internal valve collapse, external valve collapse, but then you give them some steroids and just reducing those turbinate sizes will make them, feel good enough that they could avoid a procedure. So that's usually kind of my protocol. Unless, they have zero allergies and your mid-vault is totally pinched, and then we might go straight to a procedure.